Can you hear me? No? Are we on? Perfect. Good morning, conference. Welcome to the Improving Health Outcomes Through Digital Technology and Enabler for Change session. I'm Ayub Baya. I'm the Director for Data Services at NHS England, and I'm the lead on the NHS Federated Data Platform program. It's great to be here and great to see you all this morning. I want to kick off and start with to transform what we're doing in the NHS right now and to make it truly data-enabled. We need to adopt new technology and how we work with data. There is an exciting program of work already in train nationally, and some of you may have heard Vindivika, our National Director of Transformation, speaking earlier today on this. There is also a huge opportunity to work locally to drive success, as some of our panelists will explain today. Data is a core part of how we deliver care and is at the heart of transforming services, improving outcomes, and saving lives. It is routinely collected as part of health and care services delivery. Using it well will save lives and improve the safety of the care that we provide to our patients. As Amanda Pritchard, the NHS England Chief Executive, set out on this stage yesterday, that by beginning the rollout of the NHS Federated Data Platform, with 43 trusts already using the platform, we have a credible path to how we connect the hundreds of different IT systems across the NHS over the next few years. As you'll hear from my colleagues and the panelists here today, it is already happening to support local initiatives right across the country. Historically, important information has been held in different systems that don't speak to each other, creating a burden for staff and delays on patient care. The FDP provides a consistent technical means of linking data that is already collected for patient care, allowing you to easily access the information that you need to do your jobs in one place. The technical architecture of the platform aims to drive standardization and connect both within and with different NHS organizations. Importantly, the FDP and the federation aspect of the FDP means that every trust and integrated care board will have access to their own version of the platform. They will have complete control over all of the data that's held within that platform. The FDP is one of the initiatives moving us towards achieving the objectives as was set out in the Data Saves Lives strategy and the data strategy that was updated in 2022. The strategy is the foundation of our work today, including investing more in secure data environments to power life-saving research and treatments, using technology to allow staff to spend more quality time with patients and giving people better access to their own data through shared care records and the NHS app. It's building us towards a modernized, data-enabled NHS, which will give patients more control, enable clinical efficiencies, support adoption of future-proof technology, and inform rapid, effective decision at both a local, regional, and national level. With that, I'll hand over to our panelists. First of all, we'll hear from Tom, who's from Palantir, the company supplying the software that underpins the NHS FDP. He will speak briefly on the company's journey with the NHS and the technical underpinnings of the FDP program. We'll then hear from 3 representatives from trusts who will speak of how they are driving change in their local organizations through the better use of data enabled by the FDP. We'll first of all hear from John, who will provide his perspective and the digital transformation process and the journey that he is on at Chesterfield. We'll then hear from Jo, who's from Newcastle, and she's going to tell us about her experience around driving change at an operational level in Newcastle with the care coordination solution, one of our core product offerings on the FDP. And then finally, you'll hear from Bruno. Bruno will speak about how the team at Chelsea and Westminster are freeing up clinical time from administrative work through the use of data and a new innovative set of digital tools enabled by the Federated Data Platform. Importantly, though, you will all have an opportunity to ask questions and answers, so please do engage with us. I've just put the Slido screen up, so the barcode is up there. Please do scan and ask questions, and we will be asking our panelists those questions towards the end of the session. So now, I'm going to hand over to Tom.
Thank you, Ayub. So hi, everyone. My name is Tom McArdle, and together with Joanna Pella, lead healthcare at Palantir Technologies. So we're honored to provide the software that supports the Federated Data Platform. Now, of course, I won't be speaking long. The real focus of today's session is to hear from the front lines, from the trusts, of how they're making use of the software. But I wanted to provide a very brief overview of what Palantir is, what our software does, and importantly, how our software has proven useful to the NHS to date. So for 20 years, Palantir has been building and honing technology, and specifically data platforms, to allow complex organizations to operate more effectively, to make better decisions. And that software enables those organizations to integrate sensitive data from disparate source systems, everything from legacy mainframes through to modern cloud infrastructure and everything in between. And doing so in a way that protects security and privacy. Now, what typically unites our public sector customers, whether that's the Department of Leveling Up, where we're supporting the refugee resettlement program, or it's the World Food Program, helping to optimize the distribution of humanitarian aid to those who need it most, is that these are critical organizations solving complex challenges and doing so with large amounts of sensitive information. But of course, in this country, there is no more critical institution than the NHS. So our work began in March of 2020 when COVID struck. Two of those first use cases that leveraged Foundry, our data platform, was the allocation of PPE, ventilators, and associated critical. So I'll conclude here, but we're here to hear directly from the trust, so I'll pass it over. John.
Good morning, conference. I'm extremely grateful and honoured for this opportunity. Now I've just got to get the slides to work. Hey. Okay, so my name's John. I've been a consultant in anaesthesia and intensive care medicine, working in the District General Hospital for over 22 years. I've been involved in digital transformation for approximately 10 of those, and I'm extremely fortunate to have benefited from being in the first cohort of the NHS Digital Academy. And what gets me out of bed every morning is to improve care of our patients. The hospital, just for a bit of context, is as standard as you can get. So 500 beds, 100,000 A&D attendances, 17 operating theatres, and about 22,000 procedures. And I just wanted to set that context because I think that's quite important in what I want to try and help you understand and appreciate. So I spend a lot of time working in QI, which is obviously interdigitates with the digital agenda. And the question about the CCS, which is the Care Coordination Solution, is what is it? It's not the snappiest title in the world, but what it is, it's very, very different to what you normally do when you're trying to get patients through a workflow and increase the efficiency of your operating theatres. So it's a peri-operative utilization tool, and it does clever stuff. I don't profess to know the exact details, but because it's federated, you can get your e-rosters, you can get your 6-4-2-week theatre plans, you can get your hired equipment. All of that can be seen on one dashboard, and that immediately means that you can plan and be more efficient. So that's really the what and the why. I want to talk really about the how, because when we first started looking at this, we were looking at where we thought it could help with our existing known constraints and process failure points, and that's not how it all panned out. So to make digital transformation be effective in the NHS, I believe that it should be clinically led, digitally enabled, and operationally delivered. And perioperative care is a great example of that because it's very complicated. So we looked at this platform and it's lovely. the user experience is incredible, which always helps get people on board. And we brought everyone whom this platform might touch into rooms to demonstrate the product. Everybody from healthcare assistants working in our theatres, all the way up to the chief operating officer. And more importantly, the theatre management teams and leaders and the doctors and the surgeons and the anaesthetists. And I got quite a lot of pushback going, this is amazing. We can see on this data set that we could be so much more efficient, but this is just a fictitious demo script. Where's our data? And I went, you're looking at it already. This is you. This is how you can improve. 6 weeks later, we had the theatre session management system of the CCS used in every speciality in our organisation. And it's not just the platform. We did this by utilising QSAR from NHS, quality improvement, which Joe's going to talk about later. We're slightly constrained for time, so I'll leave her to pick that up. So you can see there is some data here, and we're going to talk a lot about how we can improve, reducing variation, reducing on-day cancellations, reducing late starts, to give you some of the ideas of how you can improve your operating theatre complex. I think that we'll get into a little bit more detail later with Bruno as well, but I'm just going to finish on the fact that in the morning, my theatre management team turn this system on. They log on to this first before anything else, because they know it makes the biggest difference in their working day. And because of the flexible architecture that this software has and the way it works, is this can become business as usual in the NHS and dramatically improve our improvements on elective recovery. Thank you.
I'm going to stay sitting.
I think I may have a thank you, Sarah. There you go. That's you.
Good morning, everybody. My name is Jo McCallum, and I'm the Deputy QI Programme Director from Newcastle Hospitals. I'm here today to share how we've used digital technology, namely the care coordination solution, as a lever for significant business change across the elective surgical pathway. And just reiterating John's point about clinical ownership, I've been very much working closely with one of our associate medical directors who is really passionate about this as much as I am. I'm going to share the learning from our early adopter specialties, in the hope that you can take something away from it. Full disclosure up front, this is very much a journey, and we haven't yet reached our destination, and we probably won't for quite some time. So just a bit of context about our organisation. We are a big, large, diverse, complex organisation. We provide acute, specialist and community care for both adults and children. And we even deliver care internationally for some specific conditions. We are the second largest provider of specialised services across the country, with an income of just over £1 billion. We have 16,000 staff in 75 operating theatres, and we currently have around 99,000 patients who are on an incomplete pathway, with about a third of those awaiting admitted care. We have a significant focus on reducing the backlog, as most other acute providers do, particularly targeting those patients who have waited excessively long time for treatments. As John said, this is about staff and it's about patients. And by the time I've finished this presentation, we will have added another 3 patients to our waiting list in Newcastle, which really emphasises the importance of this work. So just a bit about our approach, and John and I didn't plan this, but we actually both approached this deployment in a quality improvement way. So I was really keen to use the science of improvement framework rather than a traditional project management, mainly so we could link it back to the key drivers of theatre optimisation, but also involve the staff who are closest to the issue with clear measures of success. So we did have fantastic project management support from our IT colleagues who managed all of the technical aspects. And I'm going to quote Marjorie Godfrey. I'm not sure if many of you are aware of Marjorie. but she is a world expert in positive change, and her quote is, "Improvement in healthcare is 20% technical and 80% human." So in a nutshell, I knew it was our staff who would determine the success of this. The project team we have to deliver is small in comparison to the size of our organisation, and I was very intentional about who I recruited into that team. I wasn't looking for digital experts, I was looking for staff who had operational expertise, and I think that's made a difference to how we've deployed this. Our lead project manager is actually a previous scheduler, so for her it's been a fantastic development opportunity. And CCS on its own is not the silver bullet, but we hoped that by integrating CCS into operational processes, we could start to really fundamentally transform existing booking practices and even develop new ones. And without the surgical pathway visibility that we have through CCS, that one version of the truth, I don't think we would have progressed as far as we have. So just going to share a little bit about the learning from our journey. So we deployed in urology, who were one of our pilot specialties, back in March 2023, and we've since deployed in 3 additional specialties. It's probably worth mentioning that urology have a significant proportion of cancer patients, and that doesn't quite fit with the 642 theatre concept, because those patients are often added to lists very late in the day, but appropriately so. We've never before had that single source of the truth incorporating our medical rotas, which has been available to all parts of the surgical system. This was very much, for me, a system-wide improvement. It wasn't just focusing on one part. And I think this has really driven the focus on we rather than me. Our perioperative team have really embraced this, and just like John said, are actively using it. And for any theatre nursing teams in the room, they're quite a tough crowd, so that made me really positive. The booking teams are really positive about the solution, but I think it's fair to say our clinicians have probably been a little bit slower to adopt, and that is where we are going to focus our attention moving forward. And I think that really links back to the role that they play within the booking and scheduling of their lists. I think we have adapted CCS, and the programme team have been phenomenal in responding to those requests. And that's because we want to ensure that we take on board feedback from the team. So if they suggest a change that we'd help them, we really want to put that into practice. And the really important part for me is the positive ripple effect that this has had across our organisation. And we have since developed a number of new change ideas that we are actively progressing, namely digital waiting list addition form, and we are looking at how we accurately capture procedure times. So whilst it's not perfect, I think I'm very sort of clear that we have proved the concept of CCS, and we are actively deploying in another 5 specialties over the coming months. The Trust will also be mandating 642 theatre policy, which is again going to really strengthen our approach to how we manage and optimise our theatres. And I'm really keen to integrate CCS as a live operational tool into our operational meetings, such as RTT, PTL, and our operational stand-ups. So if I come back to the exam question at the beginning, has this helped us to increase our theatre optimisation? One thing I will always say is CCS is one aspect of how well we plan and manage our lists. But I think the charts do tell us that we are definitely treating more patients within our existing theatres. So we're really using our existing resource in a much better way. And staff are also reporting a better day at work. And for me, that is really important. So as I said at the beginning, this is very much a journey for us, and our surgical pathway is probably still not as streamlined as it could be, but with the visibility we now have, I am very confident that we can really move towards achieving that 85% theatre optimisation, reducing our elective backlog, and providing a better experience for our patients and staff. My personal aspiration on the back of that is we remove any need for additional Excel spreadsheets and paper diaries. And if we achieve that, I will be a very happy lady. So I want to thank you for listening.
Thank you, Joe. The clock is telling me I've got 7 minutes, and I'm sorry I've been cut short, but I'm going to try and expedite a little bit. So I continue to be very thrilled to be here and be part of this panel, and over the past 2 days see how tech NHS staff are coming together to address real problems. I work at Chelsea, 7,000 staff. We have outstanding services, as an example, sexual health, that we don't provide from the hospital. We go to the heart of London and we provide directly to the community. And we've been running now an automated system, anonymized, for a number of years, where actually our ambition is to screen all, not necessarily to know who our patients are. I'm really pleased to see Joe and colleagues talking about their experience. My experience at Chelsea has been one of deploying an electronic patient record back in 2019 and still realizing that the system was quite fragmented. The past 4 years have been very exciting, the journey that colleagues have described, but ultimately is the opportunity that we have in our hands. Working with very enthusiastic colleagues in their own field of tech, subject matter experts, with healthcare professionals that up until now have been told that this is what IT is going to do for you, rather than empowering them, and actually bring the most of both expertises and coming up with new ways of working. One of those that I wanted to share with you is discharge summaries. Any doctors in the room? I've got one here and a few. Probably are familiar with this process. Every patient comes into the hospital, has to leave with a letter. That letter at the moment ranges from 10 minutes to 2 hours. What I'm able to show you on the screen is actually a real patient being done by a real doctor. I promise you, you're not going to stay here 30 minutes, because that's how long it took this doctor to do this document. But the reality is that despite an electronic patient record, when they attempt to complete that workflow, they actually have to stop because they need to open a Word document. And in that Word document, they type manually. They copy and paste information, they look into the patient record, scan through the notes, and with that, probably all the risks associated with picking up the wrong information, inconsistency of the process, because it's pretty much relying on the individual's ability and training to date to perform this task. And for colleagues who I've asked if they were doctors, probably this is a task that pretty much sits with the junior workforce, quite often just having left medical school. I said I was not going to bother you, but I was going to fast forward to 28 minutes. The doctor is still writing, the doctor is still compiling that Word document, and at some point that doctor is going to copy this information, paste in the patient record. There is a different way, though. Using the data platform is how we leverage the information that is available to us. How do we integrate, and actually how do we support the clinicians of the future? And that future is happening now. With this system, we pre-populate with information that the patient has had in their records during their hospital stay. Also, we can look into some of the information from the past medical history. The newer technology empowers the junior doctor to press a button. That pressing the button initiates the workflow where the information is going to be summarized. And within a few seconds, they get a notification to say that is done. And by the way, this is being done in real time. They continue to edit. And that process that I show you, that was taking 30 minutes, is now available just to proofread. We've instigated some safety checks at this stage, as this is all new technology, and we are working with the clinicians to strengthen and to enhance some of the functionalities. But the junior doctor goes through a referencing, so key points of that summary, whereby they have to positively check that they are okay with it. And after they've done that, they have the ability to edit, either remove information or add information. We keep that in terms of record of the system to enable us to understand what actually has happened and continue to improve. And at this stage, on this example, they've just added a salutation. They're going to go and say that. They will press submit, and the discharge summary is done. Early tests suggest that this is already as good as the human. In fact, it's very concise, is written in a language where the narrative is understood by the common mortal. I have to say, a lot of jargon sometimes goes into these documents. There's also the ability to have consistency of the discharge summaries, as we are using guidelines available from the Royal College. And with that, create a document that is actually one where the juniors are spending less time constructing, more focus on proofreading, and with that, making sure that they go back to direct patient care. So overall, patient pathways will remain very complex. We know patients are living longer with more comorbidities, but I think it's within our ability to continue this journey, make sure that we leverage technology, work with engineers in their expertise in their fields, and with that, try to continue our journey to provide better patient outcomes. Ayub.
Thank you, Bruno. So, thank you very much to our panelists for explaining their stories. I think it's really important that you hear firsthand from NHS organisations on what impact their federated data platform is making for them and for their patients, ultimately. I hope you've enjoyed listening. I apologise that we were disrupted in between. And thank you very much for attending here. If you have any further questions regarding this or anything to do with the FDP, please do visit us at stand A36. We will be available all day, as will our panelists here as well, so they'll be present there as well. Thank you very much.